As we get older, protecting our hearts becomes more important than ever. But what if one of the biggest dangers isn't your diet or even your genetics? What if it's sitting quietly in your medicine cabinet? If you are over the age of 60 and you take a daily pill to protect your heart, you need to hear this. Millions of seniors believe this medication is their ultimate safeguard against a heart attack or a stroke. But a cascade of new warnings from cardiologists and geriatric specialists is revealing a quiet truth. That very pill, the one you trust, might be the hidden reason behind thousands of life-altering falls every single year. What you are about to learn is the unspoken truth about a phenomenon called overtreatment, where the medicine itself can become the danger. This isn't about creating fear. It's about giving you knowledge, and most importantly, it's about giving you the exact, simple script to use with your doctor to make sure your medication is truly protecting you, not putting you in harm's way. This conversation could be the most important one you have for your long-term health and your independence. Section 1. The Hidden Epidemic, a story you need to hear. Let's talk about a woman we'll call Eleanor. At 75, she was the pillar of her community, organizing the neighborhood garden and never missing her daily 2-mile walk. Eleanor was also diligent about her health, seeing her doctor regularly and taking her daily blood pressure pill without fail. She called it her insurance policy. One morning, Eleanor stood up from her kitchen chair and the world suddenly tilted. The next thing she knew, her daughter was standing over her with a look of panic. The fall resulted in a fractured hip, surgery, and months of grueling rehabilitation. Her vibrant, independent life was suddenly confined to a hospital bed and a future filled with fear. Her doctors were initially stumped. Her heart was strong and her bones were reasonably healthy. What could have caused such a sudden event? It wasn't until a young geriatric specialist joined her care team that a new question was asked. He didn't just look at her charts, he looked at her medicine cabinet. He saw the small white pill she'd been taking for years. The dose, which had been perfectly safe for her at age 65, was now, at 75, a potential danger as her body had changed. Eleanor's story is not an isolated one. It's a quiet epidemic happening in homes across the country. In fact, studies from institutions like Yale University have found that taking blood pressure medication is associated with a 30 to 40% increased risk of serious, life-altering fall injuries for older adults. These aren't minor tumbles. They are falls that can lead to emergency room visits, fractures, and brain injuries. For too long, we have accepted a dangerous trade-off, protecting the heart from one threat while exposing the body to another. But that is about to change, starting right now with your understanding. Section 2. The Safe Pill Paradox. Why your body is different now. So how can a pill that is designed to help end up causing so much harm? The answer is simple, yet profound. Your body at 75 or 85 is not the same machine it was at 45. It processes everything differently, especially medications. Think of your liver and kidneys as the body's natural filtering systems. With age, these systems often become less efficient. A dose of medication that your body would have cleared out in 24 hours at age 50 might now linger for 36 or even 48 hours. This means the drug's effect can be stronger and last longer than intended. Now add another layer, a term every senior and caregiver needs to know: polypharmacy. It's a word for a simple concept, taking multiple medications at once. Nearly half of all adults over 65 take 5 or more medications every day. Each drug has its own effects, and when you mix them, they can interact in unpredictable ways, creating a chemical cocktail that no single doctor might fully understand. This brings us to the main culprit behind stories like Eleanor's. It's a condition called orthostatic hypotension. Let's break that down. Ortho means upright, static means still, and hypotension means low blood pressure. Put it together, and it means your blood pressure suddenly drops the moment you stand up. Here's what happens. When you sit, gravity pools blood in your lower body. When you stand, your body has an amazing reflex that squeezes blood vessels to push blood up to your brain. But many common blood pressure pills work by relaxing those very blood vessels. If the dose is too strong for your aging body, the vessels can relax too much. When you stand up, your body tries to send the signal to squeeze, but the vessels can't respond effectively. For a few critical seconds, your brain doesn't get enough oxygen. The result? A wave of dizziness, lightheadedness. Your vision might darken at the edges, and in that moment of confusion, you can fall. For years, many have dismissed these feelings as a normal part of getting older. We've been wrong. Very often, these are not signs of aging. They are side effects of medication. They are warning signs from your body that it is being overtreated and that you are living on the edge of a preventable disaster.
Section 3. Common culprits on your bathroom shelf. So which specific pills are we talking about? It's time to metaphorically open your medicine cabinet. I want to be crystal clear. What follows is not a list of bad drugs. These medications save lives. The issue is not the pill itself, but the dose, the combination, and the lack of regular reevaluation as we age. The goal here is to arm you with information so you can start a conversation, not to have you stop your medication. Suddenly stopping any of these can be extremely dangerous. Let's look at some common classes of medications that are most frequently implicated in this problem. Number 1. Certain antihypertensives, blood pressure pills. This includes water pills like hydrochlorothiazide and vessel relaxers like amlodipine, a calcium channel blocker, or lisinopril, an ACE inhibitor. They are the cornerstones of hypertension treatment. But for a senior, the risk is that they can work too well, leading directly to that sudden drop in blood pressure when you stand up, orthostatic hypotension. A common side effect people notice is swelling in the ankles, but the dizziness is the more silent danger. Number 2. Statins. Medications like atorvastatin or simvastatin are taken by millions to lower cholesterol and protect the heart. While essential for many, some research has linked statin use in older adults to side effects like muscle weakness and an increased risk of falls. The weakness may not be dramatic, but even a subtle decline in leg strength can affect your balance and stability over time. It's another factor that can contribute to that overall feeling of being less steady on your feet, and it's a risk that needs to be part of the conversation. Number 3. The combination, or polypharmacy. The single greatest risk may not be one pill, but all of them together. When you take a blood pressure pill that makes you a little dizzy and perhaps another medication that causes fatigue or slows your reaction time, the risks don't just add up, they multiply. This is called a drug-drug interaction, and the risk grows with every new pill added to your regimen. This is why simply adding another prescription is not always the answer. Sometimes the answer is taking something away.
The common thread is the concept of overtreatment. For decades, the medical mantra for blood pressure was lower is better. But recent evidence suggests that for adults over 70 or 80, especially those who are becoming frail, aggressively pushing blood pressure too low can cause more harm than good. The optimal target for many older adults may actually be closer to a systolic pressure of 140 or even 150, balancing the benefit of stroke prevention with the real-world risk of a life-shattering fall. If this information is making sense to you, or if it reminds you of someone you care about, please take a moment to hit the share button. This is not just a video, it's a public health message. You could be preventing a fall and protecting someone's independence. And if you're finding this valuable, please let us know by leaving a comment below. Your engagement helps this information reach more people who need to see it. Section 4. The solution. Your empowering script to talk to your doctor. Hearing all this can be unsettling, even a little frightening, but I want you to take a deep breath and let that feeling pass, because this is the moment where fear turns into power. The purpose of everything you have learned is not for you to go into your medicine cabinet and start making your own decisions or throwing your pills away. That would be incredibly dangerous. The purpose of this information is to transform you from a passive patient who simply follows instructions into an active, empowered partner in your own healthcare. This section is your detailed training manual for how to do that. You are about to learn not just what to say to your doctor, but how to think, how to prepare, and how to navigate one of the most important conversations you will ever have about your long-term health. Before we get to the word-for-word script, we must first address the biggest hurdle, your mindset. For generations, we were taught that the doctor's word is final. We go in, we listen, we nod, and we follow orders. To question a doctor can feel disrespectful or confrontational. We have to unlearn this. A good doctor does not want a passive patient. They want an engaged partner who is actively participating in their own care. Think of it this way. Your doctor is the expert on medicine, but you are the world's leading expert on you. You are the one who lives in your body 24 hours a day, 7 days a week. You are the one who feels that wave of dizziness when you stand up to greet a friend. You are the one who notices a new hesitation before stepping off a curb. Your doctor has the medical expertise, but you have the life expertise. This conversation is about merging those two pools of knowledge to create the best and safest outcome. You are not challenging your doctor, you are inviting them to collaborate with you on a shared goal, protecting your health, your safety, and your independence. Step 1. The preparation. Becoming an undeniable partner. The most effective conversations are prepared for in advance. Walking in cold will not work. You need to prepare, and the most powerful tool you have is data. This is what will make your doctor see you as a true partner. Before your appointment, you will become a detective of your own body. Your mission is to create a 1-week blood pressure and symptom log. You'll need a simple notebook, a pen, and a home blood pressure monitor. For 7 days, you are going to measure your blood pressure twice in a row, a couple of times a day, perhaps in the morning and evening. Here's the critical part. You don't just measure it while sitting down. The entire issue we are discussing is the change that happens when you stand up. So, this is the process. First, sit down in a quiet, relaxed state for about 5 minutes. Then, take your blood pressure and write it down. Second, stand up. Remain standing for 1 to 3 minutes. Don't walk around, just stand still. Third, while still standing, take your blood pressure again. Write that number down right next to the sitting one. Fourth, create a notes column. In this column, write down any feelings you experience. Did you feel dizzy? Lightheaded? Did your vision go fuzzy for a second? Did you have to grab onto something for balance? Or did you feel perfectly fine? Write it down. Your log should look something like this. Monday morning, sitting 135/80. Standing 110/70. Notes, felt very lightheaded for a few seconds, had to hold the back of the chair. Why is this so powerful? Because you are no longer relying on vague feelings. You are not walking into the doctor's office saying, "I sometimes feel a bit dizzy." Instead, you are walking in with a piece of paper that says, "On 5 out of 7 days this week, my systolic blood pressure dropped by more than 20 points when I stood up, and on those days I felt dizzy." You're showing them the clinical definition of orthostatic hypotension in action. You are presenting hard data. This changes everything. It elevates the conversation from subjective feelings to objective facts, which is the language that medicine runs on. Step 2. The opener. Setting a collaborative tone. You've made the appointment. You have your data log in hand. Now the conversation begins. How you start this conversation will determine its entire trajectory. You cannot start with an accusation or a demand. You must start by establishing that you are on the same team. Here is your opener. Memorize it, practice it, and make it your own. You say, "Doctor, I'm committed to my health, and I've been taking my medications exactly as you've prescribed. I've been reading about how our bodies change as we age and learned about the connection between some heart medications and an increased risk of falls. I want to be as proactive as possible about my safety." Let's break down why this opening is so effective. "Doctor, I'm committed to my health, and I've been taking my medications exactly as you've prescribed." This immediately shows respect and compliance. You are not a difficult patient, you're a diligent one. "I've been reading about how our bodies change as we age and learned about the connection between some heart medications and an increased risk of falls." This frames your knowledge as part of a general interest in wellness, not as a challenge from Dr. Google. "And learned about the connection between some heart medications and an increased risk of falls." You are connecting the medication to a specific negative health outcome that every doctor wants to prevent. Falls are a massive concern in geriatrics. "I want to be as proactive as possible about my safety." This is the key phrase. You are framing this entire conversation around safety. You are positioning yourself as the doctor's ally in risk prevention. This is a goal you both share. This opener is non-confrontational, respectful, and positions you as a responsible partner. Step 3. The key question: inviting a review. After your opener, you transition directly into the core of your request. You've set the stage. Now you make the ask. It must be a question, not a statement. It must be an invitation, not a demand. You ask, "Could we take a moment to review all of my prescriptions together? I'm specifically wondering if the dose of my blood pressure medication is still the ideal and safest dose for me given my current age and my goal of preventing falls." This question is brilliant for several reasons. Could we review together? The words "we" and "together" are crucial. It's collaborative. You're asking the doctor to work with you. Review all of my prescriptions. This acknowledges the potential for polypharmacy, the interaction between multiple drugs. This opens the door to a practice called deprescribing. Deprescribing is the planned and supervised process of dose reduction or stopping of medication that might be causing harm or no longer be of benefit. It's a key concept in modern geriatric medicine, and by asking for a full review, you are inviting your doctor to engage in this thoughtful process. Is the dose still the ideal and safest dose for me? Notice you are focusing on the dose, not the drug itself. You are not saying, "Is this pill bad?" You are asking, "Is this the right amount for my body today?" This respects the doctor's choice of medication while questioning if it needs adjustment. It's about optimizing, not eliminating. Given my current age and my goal of preventing falls, once again, you anchor the entire request to a tangible, important health outcome. You're giving your doctor a powerful clinical reason to engage with your question.
Step 4. Presenting the evidence, the game changer. This is the moment where you back up your words with your hard work. After you ask your key question, and before the doctor can give a generic response, you bring out your secret weapon. You say, "To help us with this conversation, I've brought a week's worth of my blood pressure readings, taken both while sitting and after standing. I wanted to see if there were any significant drops." Hand them the log, be quiet, and let them review it. This act is more powerful than any amount of pleading or describing your symptoms. The numbers on that page provide a window into what your body is doing every single day. As the doctor looks at your data, they are no longer just treating a chart or a single office reading. They are seeing the dynamic reality of your physiology. They can see the 20-point systolic drop that defines orthostatic hypotension. Your concern is now validated by clear, objective evidence.
You have given them the clinical data they need to justify making a change. You have made it easy for them to help you.
Step 5. The deprescribing question, proposing a solution. Now that you have presented the problem in the data, it's time to gently guide the conversation toward a solution. You are not telling them what to do. You are asking about a potential path forward, showing you are informed but ultimately deferring to their expert judgment. You ask, based on these readings and my goal to stay active and avoid falls, do you think a slightly less aggressive blood pressure target might be safer for me? I've read that for some people my age, a target closer to 140 systolic can be a good balance. Is that something we could consider? This final question seals the deal. Based on these readings, you are tethering the suggestion directly to the data you provided. Do you think a slightly less aggressive blood pressure target might be safer for me? The phrasing less aggressive is far better than lower dose. It speaks to medical strategy, and you are asking their opinion, which is respectful. I've read that for some people my age, a target closer to 140 systolic can be a good balance. This is a masterstroke. You are showing you have done your homework and are aware of current medical thinking that for older adults, lower is not always better. You provide a specific, evidence-supported alternative, which signals your request is based on sound medical thinking, not anxiety. Is that something we could consider? This is the perfect collaborative closing question. It's open-ended and gives the doctor the authority to make the final decision, but within the framework you have so carefully constructed.
Step 6. Navigating pushback. What to do if your doctor is hesitant. Now, let's address a real-world concern. What if you do all of this and your doctor seems dismissive or hesitant to make a change? This can happen. Doctors are busy, and established treatment plans can be hard to change. The key is to not get discouraged or confrontational. You must maintain the collaborative spirit you've worked so hard to build. If your doctor says something like, "Your blood pressure is well controlled, I don't want to change anything," or "A little dizziness is normal," don't see it as a final roadblock. See it as an opportunity for clarification. Your first response should be to calmly circle back to your primary concern, safety. You can say, "I understand that my numbers look good on paper, and I appreciate that. My biggest concern is how these numbers translate to my daily life. The feeling of dizziness is new, and it's making me genuinely worried about falling. My independence is so important to me." By saying this, you are validating their clinical perspective. "I understand my numbers look good," while gently recentering the conversation on your lived experience and a tangible fear of a catastrophic event. If they are still hesitant, you can use your data log again. Point to a specific entry and say, "On Tuesday, for example, my pressure dropped 25 points and I had to grab the counter. That's what I'm hoping we can prevent. Is there a small trial adjustment we could try for a few weeks and monitor it closely?" This is a fantastic strategy. You're not asking for a permanent drastic change. You're proposing a low-risk pilot program, a temporary adjustment with a plan to reevaluate. This is often much more palatable than a request for a complete overhaul. If the conversation is still not moving forward, you have one more powerful, respectful tool. You can ask for a specialist's input. You might say, "I deeply respect your opinion, and I want to find a solution we're both comfortable with. Would you be open to referring me to a geriatrician for a consultation? I've read they specialize in medication management for older adults, and I think a second perspective might be helpful for my peace of mind."
This is not a challenge to your doctor's authority. Instead, you're requesting to bring another expert onto the team. A geriatrician is a doctor who specializes in the complex health needs of older adults, and they are masters of deprescribing and managing polypharmacy. Suggesting a consult shows you are serious, informed, and ultimately focused on the safest possible outcome. A good doctor should support this request. You have now completed the process. You have moved from being a passive recipient of care to being the CEO of your own health team. You have presented a concern, backed it with data, respectfully asked for a collaborative review, and navigated potential pushback with grace and firmness. The single most important message you should take away today is this: you are your own best health advocate. For too long, we have dismissed dizziness, fatigue, and unsteadiness as inevitable consequences of aging. Now you know they could be clues. They could be treatable side effects.
That slight head rush when you stand up is not something to be ignored. It's a signal to be investigated. You now have the knowledge and the tools to start one of the most important conversations you will ever have about your health. That single conversation, using the script you just learned, could be the step that preserves your mobility, your confidence, and your independence for years to come. Schedule that medication review. Take control of your health. Your future self will thank you for it.